for visiting the eye casualty clinic regarding if this patient is a pseudopapilloedema or really has optic nerve head swelling from either neuropathy or papilloedema. For us, we can't refuse such referrals, and we need to do our best to make sure that we are doing the correct diagnosis. Simply, we need to differentiate optic nerve head pseudoedema from true swelling. It's not an isolated ocular examination that would differentiate this, but you should take into account the full systemic association of the condition. If the patient has headache, if the headache worsens with supine positioning, you need also to take the clinical appearance of the optic nerve head itself. And we'll be talking about this in the next slide. The cause for the following slides is the clinical appearance sometimes is tricky, and we can't determine exactly if this is really true swelling or pseudoedema. So we have the ancillary testing, which might not be available as out-of-hours investigation, but still we'll be talking about all of this, like ultrasound, CT, MRI, fluorescein angiography, and autofluorescence, OCT, and even electrophysiology. Ultrasound is sensitive. It is a second sensitive tool for diagnosis of optic nerve head pseudoedema. It shows high echogenic shadow that persists with low gain even if you lower the gain, just like detecting a retinal detachment and differentiating it from a posterior vitreous detachment. It just remains, the echogenic shadow remains. So this is very important. It's accessible to every one of us out of hours, but it needs an experience at hand. Optic nerve head drusen is a calcification. So CT can determine the calcification of the optic nerve head, but the problem is it's less sensitive. It has 1.5 millimeter cuts and has high radiation exposure, and I believe it's not justified to request a CT scan just to see if this patient has a drusen or not. MRI does not detect optic nerve head drusen. Some other tests that might not be available as out-of-hours tools. The fluorescein angiogram. Usually, the optic nerve head shows late staining in the late frames. But in true edema, in true papilloedema, it shows late leakage. Not staining, it shows true leakage. Just as if there are some neovascularization in the disc from diabetic retinopathy or whatever, it looks nearly the same. Autofluorescence is less sensitive than B-scan. It shows nearly half the sensitivity of B-scans. However, it's a valuable tool in determining the nature of the optic nerve head swelling. Enhanced depth imaging, OCT, is nearly the most sensitive tool at all. It shows hyperreflective structures. It's evident from the OCT scans that there is some structures enclosed in the substance of the optic nerve head. This is a very valuable tool. Electrophysiology also, but this is not requested for such diagnosis. So this image shows abnormal optic nerve heads that we need to see if this is true papilloedema that needs urgent lumbar puncture maybe, or is it just pseudopapilloedema and optic nerve head drusen. Secondary to the systemic symptoms that you should be interviewing the patient for, I would consider the clinical appearance of the optic nerve hit. So as you can see here, the optic nerve has obliterated cob, and the margins of the optic nerve head is still, you can detect them anyway, okay? And there is this faint circle that we'll be speaking about now. And the gold standard for determining if this true swelling or pseudopapilloedema and optic nerve head drusen are the blood vessels. So the magic word is blood vessels in papilloedema are swollen, engorged, tortuous, and there are some blood vessel, bleeds on the margin of the optic nerve head. However, in optic nerve head drusen, the optic nerve head looks swollen, but the blood vessels are normal caliper, maybe slightly dilated, but not engorged, and not tortuous. And there are some other vascular abnormalities, like celioretinal arteries emanating from the optic nerve head, trifurcation, which is the blood vessel branches into 3 different branches on the same time, rather than this regular bifurcations. And you can see it here. It's a trifurcation of a blood vessel. Larger caliber, but they're not engorged. And something else, they are running for a longer distance without branching. So they can just remain branched once before the edge of the optic nerve head and then running for a long distance without giving any branches. Okay? So the clinical appearance is very important. The cause of papilloedema is not true fluid exudating into the substance of the optic nerve head. The cause of papilloedema is problems with the exoplasmic flow of the optic nerve head fibers. So it's a swelling of the individual optic nerve head fibers. In this case, there is no exoplasmic disturbance and no true swelling. So the optic nerve head is slightly elevated, and this line determines that the RNFL is not swollen beyond the margins of the optic nerve head. So this circle is really valuable in determining the nature of the swelling. This takes us to other pathologies like crowded optic nerve head in high myopic patients, who again show obliterated cup because the same number of RNFL are going out from the eye through smaller diameter opening, a smaller optic nerve head. Another pathology is the impending retinal vein occlusions. So you can see that the blood vessels are slightly engorged, tortuous, and if you search carefully, you'll find subtle bleeds in the substance of the retina itself. For these patients on the right with impending RVO, you need to do systemic evaluation. 60% have associated systemic comorbidity. For the right eye, for the slide to the left, you don't need systemic evaluation because this is crowded optic nerve head from high myopia or whatever. So we come now to the ancillary testing for optic nerve head drusen. As I've mentioned, OCT scanning is the most valuable investigation in these patients. The image on the top is for a patient with papilloedema, and here you have engorged blood vessels, obscuration of the blood vessels at the disc margin. This is not a color photo, but I still can detect these changes. It's in contrast to the other patient with optic nerve head drusen who has smooth blood vessels, no engorgement, no tortuosity. So this is a swelling. You believe that all axons are swollen without discernible structures inside, in contrast to the bottom one, which shows you believe that there are encapsulated structures down there. Second issue, a second point to differentiate between true swelling and pseudopapilloedema is a Brock's membrane. Brock's membrane in true papilloedema is pushed forward, while in cases with optic nerve head drusen, it's not pushed forward. This is a very important sign. So this is a OCT scanning for papilloedema, optic nerve head drusen, and congenitally crowded optic disc. As you can see, the thickness map, thermal thickness map, for papilloedema, it's mostly thickened from up and downward, inferior and superior, which are the thickest parts of the RNFL. While in optic disc drusen, it's just not that thickened beyond the margins of the optic nerve head, and it's nearly global or irregular in relation to the parts swollen with the optic nerve head drusen. While in congenitally crowded discs, it's all around. And again, here you can see how the Brock's membrane is pushed forward, while in optic nerve head drusen, not pushed forward. Usually, the RNFL thickness map does not contribute to the ONHD diagnosis. It's more valuable in papilloedema, where we use it to trace the progression or regression of papilloedema, but in optic nerve head drusen, usually it shows normal thickness, because this circle in 3D OCT scans, this circle has a diameter of 3 millimeters, and the optic nerve head diameter, the optic disc diameter, is only 1.5 millimeter. So this shouldn't be affected in drusen, optic disc drusen. However, if there is true swelling and the RNFL is really swollen beyond this point, it will be captured by this map. So this photo shows, again, optic nerve head drusen. Blood vessels are just normal, not engorged, not tortuous, and not obscured by the RNFL fibers. And here this circle again means that the RNFL around the optic nerve head is not swollen. This is a B scan of optic nerve head drusen and shows this high echogenic shadow that persists even after lowering the gain. And this is the autofluorescence image showing the autofluorescent nature of the optic nerve head drusen. So we should now be moving to